Welcome to the debate. Before we dive into today's discussion, just a quick reminder to please like, subscribe, follow, and turn on the notification bell so you never miss an update.
Yes, please do. It really helps the show.
Absolutely. And I also want to provide a very brief update on the Martin Stevens versus OpenAI matter. Just to be explicitly clear here, this is not a lawsuit. We are continuing to monitor it, but we are currently in a voluntary quiet period at Martin's request.
Which makes total sense given the situation.
Right. I do not know if any settlement discussions are actually underway right now, but we're hoping for a settlement in the background. And most importantly, I can report that the dead man switch has not been activated, meaning Martin Stevens is physically and legally safe.
That is honestly the best news we could hope for.
It really is. All right, so to the issue at hand. Imagine an emergency room dealing with a mass casualty event. They don't just leave the doors wide open, right? They implement a strict diversion protocol to save the patients they already have.
Right. You temporarily halt the intake of new patients.
Exactly. You do it to ensure the system has the capacity to thoroughly treat the ones you are legally obligated to accept. So today, we are asking if the CDC is doing exactly that with its latest border policy, or if they are just locking the doors based on what passport you hold.
And we really need to look at the context here because the World Health Organization has just declared the rapidly escalating Bundibugyo Ebola outbreak in the DRC and Uganda a public health emergency of international concern.
Yeah.
And the numbers are just, well, they're incredibly grim. We are looking at over 100 deaths, more than 300 suspected infections in the DRC. And an American medical missionary is already infected.
Which is tragic, and that brings us to our central question. The CDC has invoked a Title 42 order. For those who don't know, that's a public health directive that allows the government to suspend the entry of individuals into the U.S. to prevent the spread of communicable diseases.
Specifically, they're using it to temporarily ban entry for non-U.S. passport holders from the DRC, Uganda, and South Sudan.
Right. And I view this 30-day restriction as a mathematically necessary strategic pause. It is a triage measure designed to protect our domestic health infrastructure from a highly lethal virus with a very long incubation period.
But look at what Title 42 actually does here. I mean, it's a sledgehammer being used on a problem that requires a scalpel.
A sledgehammer?
Yes, this restriction is entirely disproportionate to the CDC's own assessment, which, by the way, states that the risk to the U.S. remains strictly low. And more importantly, it fundamentally ignores how this virus actually operates in the real world. It is strictly symptomatic and non-respiratory.
Well, let's talk about the biology driving this, because it explains exactly why that sledgehammer feels necessary. We're dealing with the Bundibugyo strain, which carries a 30 to 50% fatality rate.
It's incredibly dangerous, yes.
And unlike the more common Zaire strain of Ebola, there are 0 FDA-approved vaccines and no proven antiviral therapeutics for Bundibugyo. But the core biological threat is the 21-day incubation period. For up to 3 weeks, the virus acts like a stealth bomber.
Okay, but
Just hear me out. It is actively replicating in the host's cells, but it suppresses the body's early immune alarms. The person feels perfectly fine while walking through major international aviation hubs like Doha, Dubai, or Addis Ababa. They're completely unaware they are a ticking clock.
wait, let me stop you right there. I understand the fear of a crowded transit center, but we have to stick to the biology.
I am sticking to the biology.
You're talking about a stealth bomber, but the epidemiological reality of Ebola, any strain of Ebola, is that asymptomatic individuals are not contagious. Full stop.
But they eventually become contagious.
Yes, but unlike a respiratory virus like COVID-19, where someone might be breathing out pathogens while just ordering a coffee, Ebola Bundibugyo only spreads through direct contact with symptomatic bodily fluids. Banning individuals based on their passport status rather than verified exposure is just scientifically arbitrary.
I don't see it as arbitrary when we are managing finite resources.
But we already have exit screenings in the DRC and Uganda actively managing this risk based on actual symptoms.
But are you not placing an enormous amount of faith in the exit screenings and human self-reporting. I mean, we know people can pass a thermal scanner at an airport in Africa while in that stealth bomber phase, fly to JFK or Atlanta, and then, 3, 5, or 10 days later become highly infectious while navigating the United States.
Right. But worrying about this spreading in an airport like COVID-19 is like worrying about getting a sunburn from a flashlight. The mechanism just isn't there.
A sunburn from a flashlight? That's a bit dismissive of a virus with a 50% mortality rate.
I'm not dismissing the virus, I'm talking about the transmission. Listeners hear the word Ebola and immediately picture the 1995 movie Outbreak. People catching it through the air in a movie theater. But we have to separate Hollywood from epidemiology here.
Obviously, it's not airborne.
Right. So if an incubating traveler develops their first fever in a crowded terminal at Chicago O'Hare, they aren't coughing a cloud of infection over the TSA line.
I see why you rely on the lack of aerosolized spread, but let's talk about human behavior. If someone starts sweating, experiencing severe gastrointestinal distress, or vomiting in a crowded terminal at O'Hare, they don't instantly teleport to a sterile isolation ward.
Well, no, of course not.
Exactly. They are touching surfaces, using public restrooms, seeking help from staff. Doesn't the sheer density of a U.S. transit environment create an unacceptable risk of bodily fluid contact, regardless of it being non-respiratory?
It creates a risk, certainly, but a low one, as the CDC itself admits. And historically, we've managed that exact risk without banning nationalities.
This situation is different.
It is. Look at the 2022 Ebola Sudan outbreak in Uganda or the 2024 Marburg outbreak in Rwanda. In both of those instances, the U.S. successfully relied on funneling passengers to specific domestic airports equipped with enhanced screening. We didn't invoke Title 42 to shut the door on non-citizens. So what biological factor justifies escalating to a border closure this time?
It's not just the biology of the virus in a vacuum, it's the collapse of containment at the source. This isn't playing out in a stable region. The outbreak epicenter is the Ituri province, which is a highly volatile conflict zone.
It is, yeah.
We have active infections among American medical personnel right now. Dr. Peter Stafford from the Surge Christian Mission was infected, and he, along with 6 other high-risk exposures, had to be evacuated to Germany.
And we are all grateful they got out.
Right, but when you have weak health infrastructure compounded by active armed conflict, containment efforts on the ground are drastically limited. The source country simply cannot track contacts or catch every exposure.
That is a compelling argument about the danger on the ground, definitely. But have you considered the actual physics of global travel?
What do you mean?
Does the geographical danger for responders in the Ituri province actually change the biological transmission dynamics of the virus once a traveler is on an airplane? Once they leave that conflict zone and enter the international aviation network, the virus behaves exactly the same way it did in 2022.
But the sheer number of untracked exposures.
Look, if an American citizen and a Ugandan citizen are sitting next to each other on a flight from Addis Ababa, they pose the exact same biological risk to that Chicago terminal. Yet Title 42 lets one in and bans the other. That is the definition of arbitrary public health policy.
It is triage. And triage requires hard boundaries to preserve capacity. By restricting non-U.S. arrivals, the CDC is making sure our finite resources, like our port health protection systems, our specialized isolation units, are strictly reserved for the returning citizens we are legally obligated to accept.
Even if those non-citizens pose no greater biological threat.
We need that 30-day buffer to scale up. For example, we have BARDA, the federal agency responsible for developing medical countermeasures, racing to engineer monoclonal antibodies right now.
Right.
These are essentially lab-made proteins designed to mimic our immune system and fight off this specific Bundibugyo strain. Furthermore, we have massive, complex, imminent events approaching. I mean, Houston is set to host the DRC World Cup team.
Oh, wow. Right. I almost forgot about that.
Yeah. You cannot meticulously plan the logistics and public health protocols for an event of that magnitude if the system is simultaneously flooded with routine international arrivals from the hot zone.
I absolutely acknowledge the complexity of managing an international event like the World Cup,
But if we look at the actual text of the Title 42 order, it includes exceptions that completely undermine the strict quarantine logic you're defending.
How so?
It allows for Department of Homeland Security approved processes, and it leaves room for customs officer discretion on a case-by-case basis. If the virus is so deadly and the resource strain so severe that we need a hard boundary, why are we leaving the door cracked open for bureaucratic discretion?
Well, there always have to be emergency exceptions.
It proves that this is a border management tool, not a purely medical one.
I hear your concerns about the bureaucracy. I really do. But ultimately, this restriction is a necessary, proactive measure. It's designed to prevent an untreatable, highly lethal pathogen from slipping through that 21-day incubation blind spot, buying the U.S. the critical time it needs to scale up our domestic health infrastructure and testing.
And from my perspective, invoking Title 42 improperly targets a traveler's passport status rather than their actual exposure. It completely ignores the proven efficacy of symptom monitoring for a non-respiratory virus. I mean, it is a blunt instrument for a pathogen that requires precision.
Despite our different frameworks, I think we both clearly converge on the fact that the Bundibujo strain is a profoundly serious pathogen, especially given the total lack of approved vaccines or treatments.
Absolutely. And we must also acknowledge the immense bravery of the American medical personnel, like Dr. Stafford, who are operating on the front lines in the DRC. Their dedication in those logistically fractured conflict zones is extraordinary.
It truly is. I highly suggest our listeners continue following the CDC's ongoing risk assessments as the situation evolves. Ultimately, this debate exposes a terrifying gap in our globalized world. Our aviation networks move at the speed of jet engines, but our pathogens still incubate at the speed of biology.
Well put.
When those two timelines clash, we have to ask ourselves how best to protect the public.
The biology and the bureaucracy rarely speak the same language, which is why interrogating these policies is so vital.
Exactly. As we wrap up today, please remember to like, subscribe, follow, and turn on the notification bell. Thank you for joining us on the debate.